Not getting a scoliosis brace can cost you up to $23,000. You see, a brand new research paper was actually published in the Journal of Pediatric Orthopedics. And in this study, they looked at what does it cost patients where the scoliosis is caught early and they get a brace and they end up avoiding surgery compared to those where the scoliosis is not caught till it's gotten bigger and they're beyond the point where they can be treated with a brace and they end up getting surgery. Hi, I'm Dr. Chris Goebbels, leading authority in the non-surgical treatment of scoliosis. And in this video, I'm going to go over what the actual financial costs are of not getting the right treatment. But beyond just the financial cost, there's the emotional cost of dealing with the condition, not getting the right treatment. There's a psychological cost of dealing with a spine deformity, but then also the economic cost of paying for bigger or more severe treatments or more involved treatments because the scoliosis was not actually treated properly. Now, if you're watching this and your child has scoliosis, be sure to click on the link below and download our free guide called The 4 Critical Factors to Getting the Right Treatment for Your Child. Now, what's interesting about this research study is they looked at all the patients that came into an orthopedic center, and they looked at the patients that were candidates for treatment. Now, some of those people actually got the right treatment for scoliosis braces, and some of the people did not get scoliosis braces. And they looked at the actual economic cost for the patients for both those that got bracing and those that ended up getting surgery. They looked at the direct cost, which is the bills they actually had to pay or that the insurance had to pay, but they also looked at the indirect cost of treatment, which is time away from work, travel, things like that, all the other potential expenses that could be involved. So this is the actual research study. It's called The True Cost of Late Presentation Adolescent Idiopathic Scoliosis, a 5-year study. And as they said, is like each patient who was prescribed a brace and avoided progression to surgical ranges actually saved $23,000 in treatment. Now, this also would eliminate or save in one institution anywhere from $2 to $3 million per year. So that's what it actually saved per institution, but $23,000 in treatment per patient. So the Scoliosis Research Society actually recommends bracing for scoliosis at curves between 25 and 40 degrees with Risser 2 or negative. Risser sign is a way we can measure skeletal maturity. So they're basically saying kids that have not reached skeletal maturity that have a curve between 25 and 40 degrees. Now, in this research, they looked at people that had curves in this area that could have been candidates for brace. Going back to this study, they said there was significant cost savings can be found by optimizing the number of patients treated with the brace and minimizing the patients that present late, which means your scoliosis was not caught until it's later on, which means they're older or the curves have got more severe, likely, and then at that point, they're likely surgical candidates. So this is when someone is Risser 2. This is how we measure the Risser scale. It's a way to measure skeletal maturity. This is actually a Risser 2 patients. So patients who are at this level of skeletal maturity or lower and have that curve between 25 and 40 degrees were deemed to be candidates for bracing according to the SRS or Scoliosis Research Society. Now, in this study, they said if a curve was beyond 50 degrees, that's when they become a candidate for surgery. And if curves are less than 40 degrees and they're less than Risser 2, although they're not at 50 degrees, they're really likely to end up getting surgery. So basically what they did in this study is they said, hey, when they first came in and got their first appointment, where were they at? And they looked at how many patients were in this criteria. If they were in this criteria, they actually received the bracing. If they were in these criteria when they first came in, that was a late presentation, meaning their curve was not caught till it was late, and they were too late to have a brace, and they were deemed they needed to have surgery. So they were looking at how many of these patients down here, when they first came in, were surgical candidates that ended up getting surgery or recommended surgery. And if they would have been caught when they were smaller, if we could have prevented the surgery, how much money would have that actually saved? That's how they came up with these overall numbers. So they looked at 373 AIS or adolescent idiopathic scoliosis patients, which are basically teenagers that have an idiopathic scoliosis. Of those, when they first came in, 63 or basically 16.9 or 19% were ideal brace candidates when they first presented. Of those, 16% still progressed to surgery. So the bracing had an 84% success rate of patients that got prescribed a brace of their curves not progressing to surgery. So 27.6% of the 373 were considered late, or by the time they first came in, their curves were already at surgical levels or at 40 degrees, and they were still young and immature with a lot of growth left, so a high predictor of them progressing to surgery. Of those, 80% ended up getting surgery. So of these 103, a lot of those, if they would have been caught earlier, are the ones that could have prevented surgery and hence really had a big economic savings. Now, what's interesting when we look at these, the ones that caught earlier, the average age was under 13. I think it was about 12.7 years of age. And of these, the average age was 13.7. So what I mean is when we caught in the study, when they found people that were younger, on average age of 12.7, their curves were smaller and they were not as old. So they were more likely to be candidates for the brace. The ones that their scoliosis first detected when they were older, on average 13.7, they were considered late presenting, or they were older when the curve was first detected, which meant they were likely to have larger curves and people that were more likely to be candidates for surgery because they'd already missed that window or they were late presenting. Now, this is why this is important. When you're born, you grow super fast, and that growth slowly decreases till you're about 5 years old. From about 5 to the beginning of puberty, your rate of growth is nice and steady, and it's actually fairly slow. And also during that time frame, when you're during your childhood years, the majority or the higher percent of growth actually comes from your spine. But right here with the onset of puberty, which is typically between around 10 and 12 in girls and 13 and 14 in boys, with the onset of puberty, you have a shift in growth rate and you grow super fast, especially for the first 2 years of puberty. That's the dotted line. You have your peak height velocity where you grow really rapidly. But what also happens is the percent of your growth actually happens from your spine. So during these first 2 years of puberty, that's when curves are the higher risk of progression. So when the curves were detected in people when they were younger, they were more likely to be early on in this phase, and hence their curves were smaller and they were better candidates for brace. When people's curves were first detected when they were older, they're more likely to have more curve progression or to be later on and have larger curves or have 40-degree curves and they were already beyond risk or two. But if the curves were picked up later in the life, they were more likely to have missed that window of opportunity where bracing was still an option based on the brace criteria that was used in this study. Now, here's what they found: the non-operative versus operative treatment costs. Brace treatments, the ones that got a brace, the actual cost was about $10,000. Now, of that, about $4,000 was out of pocket for patients, and about $6,000 was expenses actually covered by the health insurance. For those that received surgery, the cost was about $50,000. Now, this was done in Canada, and surgical costs in the United States are actually much higher, many times over $250,000 to $300,000, so even greater. But the cost of non-surgical treatment in the United States, this is about what you would see with most patients that are getting custom bracing and scoliosis-specific rehab, but this is much higher in the United States for surgical treatments. Now, you may be thinking, well, the difference between $50,000 and $10,000 is not $23,000. Why did catching curves early only save $23,000? Because they assume that some people, even if they were braced, would still end up having surgery. But overall, if we catch these early and we get brace treatment, on average, that's going to save $23,000 per patient. Now, why is this so important? The reason it's so important is because it's evidence financially that if we catch curves earlier and get people the right treatment earlier on, we know it saves both people and the system money. But beyond that, we also know that people get better results. You see, all big curves start off as small curves. And we know if we catch curves early, we can get earlier and better intervention, we can get better outcomes. And one of the conclusions of the paper is because of this information, it's critical that primary healthcare providers know how to accurately detect and evaluate scoliosis, so we're more likely to catch those early. And the reason it's so important for primary healthcare providers to be able to detect scoliosis is we do not have scoliosis screenings in our school systems anymore in the United States and mostly in Canada. Now, if you're like me, when I grew up, we actually had someone come in our school and do the scoliosis screening where they did the forward Adams bending test where they had us put our hands together and bend over and they were looking for signs of scoliosis. We don't do that anymore. So you may be wondering, if we know catching scoliosis early can lead to early and better treatments and likely prevent surgery, why do we not do scoliosis screenings? Well, let me give you a little backstory on why we do not give those. You see, there's something in the United States that's called the Preventative Service Task Force Organization. And in 2004, the Preventative Service Task Force recommended against scoliosis screenings. Now, one of the reasons they recommended against screenings, there was a research paper published between two surgeons, and then it wasn't based on any scientific data, just their opinion that there's no treatments outside of surgery that can help scoliosis. So based on that information, this task force actually made recommendations against doing scoliosis screenings. But this is actually what the task force said in 2004. The task force recommended against routine screenings of asymptomatic adolescents for idiopathic scoliosis. By the way, almost all teenagers with scoliosis are asymptomatic. The majority do not have pain. Some have pain, but the majority don't have any symptoms at all. They stated the rationale in the summary of the recommendation concluded that the harm of screening, so the rationale was the harms of screening for adolescents for idiopathic scoliosis exceeded the potential benefits. So they're saying that doing the screening was potentially more harmful than actually doing the screening. Since that time, this was actually published in 2013, at least 5 states had removed scoliosis screenings from their schools based on this. But now today, it's currently 2025, 100% of the schools in the US have removed their screening programs. So this is actually the paper, is the review of the impact of these recommendations. Later on, I think it was in 2018, the task force said there's insufficient data to support screenings. And I'll tell you why that's important here in a second. So in this paper, going over the impact, here's what a conclusion of this review of the impact of this said. They said that the United States Preventative Service Task Force recommendation has reduced the number of screening programs in the United States, which was their goal, which is consistent with the intent policy. So they made these policies to get rid of screenings because obviously they thought screenings was more harmful than not doing screening. However, what they also say is that contrary to the task force stated rationale, the reduction in scoliosis screening appears to have caused more harm, not less, for idiopathic scoliosis patients and society as a whole in terms of increased volume and the economic burden of scoliosis. So you had this task force that was designed and they made the recommendation saying that doing the screenings caused more harm and more economic loss and more problems than not doing screenings. But because of that, we dropped all these screening programs. And since we dropped all the screening programs, the number of people whose scoliosis does not get caught until later on in life has increased. And the number of surgeries has increased. And that has caused both more surgeries that are needed, but it's also caused a bigger economic problem for our overall systems. So the task force recommendation, yeah, they reduce screenings, but we know it's actually caused more harm because people do not get the treatment that they recommended. Now, since then, the Scoliosis Research Society has actually changed their recommendations. And this research paper published in 2013 was a landmark study that showed that bracing is highly effective in reducing the likelihood of progressing to surgery. And in this study, patients were basically randomized or self-selected into 2 groups, either getting a brace or not getting a brace. And halfway through the study, they actually stopped the study because it was obvious bracing was so effective at preventing surgery. It was unethical to not give them the chance to have a brace because we knew the brace could reduce the likelihood of their curves progressing from surgery. Based on that study, some recommendations have started to change. The SRS, or the Scoliosis Research Society, is the International Society for Surgery for Scoliosis. They now recommend that we need to do early screenings to catch these curves. This is their actual recommendation right here. This is the Scoliosis Research position paper on screenings. They said there's high quality studies have now established that non-operative treatment with bracing or scoliosis specific exercise may reduce the number of patients progressing to surgical levels. But to be effective, these treatments need to be applied to smaller curves prior to skeletal maturity. This places an emphasis on the need for early detection of scoliosis. So they recommend doing screening using what's known as the forward bending Adams test, using what's called the scoliometer, which is a device we use to measure rotation. And if there's certain parameters, about 5 degrees of deformity, that's the threshold, that's a positive test. And so if someone on a screening, if you think someone may have scoliosis, then you would take an x-ray to rule in or out scoliosis, and if scoliosis is there, what the appropriate treatment is. They also recommended that girls be screened at the ages of 10 and 12 years old, and then boys be screened between the age of 13 and 14. Now, the reason we screen girls earlier is because they hit their growth spurts earlier. So if you have a child that's never been screened, they should be checked at 10 and again 12 years old. If you have a boy, between 13 and 14. But there's likely no screening program out there. So you need to know what to look for in your child to see if they may have scoliosis. And that's something we discussed in some of our other videos. But you can also bring your child to your pediatrician. I've had mixed experience with pediatricians. I have some pediatricians that catch these things when they're super small and they send them to us to see if they're candidate for treatment, and if not, to actively be observing and checking their kid to see if the curve is worsening. I have other pediatricians who kind of poo-poo treatment and say it's not a real big deal. And then before we know it, the curves progress and their child ends up getting recommended for surgery. So here's my recommendation. If your child has scoliosis, or even if you're adult watching this and you have scoliosis, you should click on the link below and request a free discovery call. We can review any x-rays you have or posture pictures, and we can let you know how big or severe the curve is, the risk of progression, and what treatments may be appropriate for your child. Now, if you know you already have scoliosis and you're watching this because you're trying to figure out what to do or what treatments work or what don't work, what I recommend is watching our next video to learn more about the most effective treatments for scoliosis.